Great. So I'd like to welcome you all today. Good morning. And it's with delight that I introduce Dr. Richard Isaacson, who's the founding director of the Alzheimer's Prevention Clinic at Weill Cornell Memory Disorder Program, assistant dean of faculty development, and associate professor of neurology at Weill Cornell Medicine and New York Presbyterian. He completed his residency in neurology at Beth Israel Deaconess Medical Center, Harvard Medical School, and his medical internship at Mount Sinai Medical Center in Miami. Dr. Isaacson now specializes in Alzheimer's disease risk reduction and treatment, mild cognitive impairment due to Alzheimer's disease, and preclinical Alzheimer's disease. His clinical research has shown that individualized clinical management of patients at risk for Alzheimer's dementia may be an important strategy for optimizing cognitive function and reducing dementia risk. He's published novel methods on using a precision medicine approach in real-world clinical practice of AD risk reduction. He previously served as neurology residency and clerkship director, and his career in education spans undergraduate, graduate, and continuing medical education, as well as patient, caregiver, and community education and outreach. He led the development of Alzheimer's Universe, a vast online education research portal on AD with greater than 2 million unique visitors since 2018. With a robust clinical practice, focus on multi-domain lifestyle interventions, and broad background in computer science, mHealth, biotechnology, and web development, Dr. Isaacson is committed to using technology to optimize patient care, AD risk assessment, and early intervention. The Alzheimer's Prevention Clinic also studies digital biomarkers using a wearable biosensor and aims to rigorously evaluate the effects of personalized, evidence-based multimodal interventions on cognition, serum radiologic biomarkers of AD, and calculated AD and cardiovascular risk. And he also plays in a band called the Regenerates. So it's a great pleasure that I introduce Dr. Richard Isaacson, who's going to speak about individualized clinical management of patients at risk for Alzheimer's disease. Thank you so much.
Great, Nancy. Thanks so much for the invitation. Thanks everyone for joining. I have a nice group online, and that is the first time I've ever been introduced with the Regenerates in my bio. And the fact that this is going to be online one day, we have like 101 followers on Facebook, and I'm telling all of my old bandmates that we finally got a shout out. So that's pretty cool. And I see some familiar faces online. So hello. And I see some people I haven't met yet. So new friends and old friends. And if that's the Rick Hodes that I think it is, thanks so much for coming. We haven't spoken in a while, but great to have you on. If that's you, if it's not, and it's like your twin brother or same name, well, you have a great name. Okay. So I'm going to share my screen and I am going to, let's see, find my slides. This is kind of like a brain test. And the goal of today's presentation is to, try to give you a broad brush overview of what the heck is this new field of preventative neurology. And in that field of preventative neurology, can we support brain health, maintain brain health, and most importantly, reduce risk for, or even possibly prevent Alzheimer's disease? And, from a preventative health perspective, we haven't really thought of Alzheimer's disease and dementia as a disease that really has any degree of prevention possibilities. My brother's a Parkinson's specialist. He's, a little bit older than me, a fair amount older than me. And when he heard I was doing this, Alzheimer's prevention clinic thing back in 2013, he said, "What? You can't prevent Alzheimer's. You can't do that." Well, he's a Parkinson's specialist. And now this summer, we're going to be hiring a movement disorder specialist to focus on risk reduction for Parkinson's and Parkinson's prevention and Lewy body prevention. So, the field of neurodegenerative diseases, we really have to start thinking about prevention as early as possible. And hopefully over the next, 30, 40 minutes, I'll try to, give you some of the reasons why and try to explain that it truly is evidence for this. Based on the 2020 Lancet Commission, the Lancet Commission put together a report based on modifiable risk factors. At least 40%, 4 out of 10 cases of dementia may be preventable if that person does everything right. And that's our goal, to educate patients, to try to follow patients longitudinally. And then most importantly, we need to evaluate what are truly the outcomes, because you have to promise not to overpromise. And I really believe that. You can't just say, "Oh, we're going to prevent Alzheimer's. You're going to reverse Alzheimer's." Like I don't use those terms. I say we're going to do everything possible that we can, and then we're going to track your own self over time to give you that, some degree of evidence of that we're making progress, or if we're not, we better recalibrate. So with that as an aside, we'll talk about grant support and disclosures. Been funded by a variety of folks, American Academy of Neurology, NIH, Women's Alzheimer's Movement led by Maria Shriver, also the NIH Clinical Research Loan Repayment Program. I have a ton of student loans. I'm 20 years out of school now, but I'm still paying off my loans. So I'm appreciative to the NIH for taking the edge off at least. Had a lot of philanthropy. When I started in this field in preventative neurology and preventative dementia, like there were no grants at all for this stuff. There are still minimal grants, but if it wasn't for philanthropy, we just wouldn't be able to make much progress. When it comes to other disclosures, I'm a trustee of the McKnight Brain Research Foundation that focuses on cognitive aging. But by far my disclosure or bias related to this presentation that has changed the way that I look at both medical practice as well as neurology and dementia is my Uncle Bob and my dad's first cousin, Charlotte. So this is a picture of my family, Flatbush, Brooklyn, May of 1946. It's my cousin Erwin's bar mitzvah, in case anyone was there or has relatives that were there. Who knows? Lots of Brooklyn natives, even on the West Coast, East Coast. We're all dispersed. And basically, in this picture, 4 relatives ended up being diagnosed with Alzheimer's disease in future years, and that number is really striking. And what we don't realize is that Alzheimer's disease begins in the brain over 20 years before symptoms. So, as an example, you see a lot of young, vibrant people in this picture, but there are people that had the first stages of Alzheimer's. And in this case, it's my Uncle Bob. He's 31 years old, and he's still young enough and to have no symptoms, no pathology. He's age 31. But as the clock just ticked a little bit further, he had normal memory, but at the age of 45, the pathology has started in his brain. At age 45, he has Alzheimer's, stage 1, preclinical, pre-symptomatic Alzheimer's. Then he started having those senior moments, and they said, you're fine. I'll see you back in a year, see you back in 5 years. No, that was mild cognitive impairment, the precursor stage to Alzheimer's disease dementia. That was MCI due to Alzheimer's. And now at age 72 is when he got this magical diagnosis of dementia due to Alzheimer's, but the disease started in his brain at the age of 45. So Alzheimer's disease, is a multi-decade disease. And if we can recognize that, I believe we can do something about it and intervene. So just kind of taking these statistics home a little bit, if at the age of 85, 45% of people have Alzheimer's, and these statistics range quite a bit, that disease first started in their brains between the ages of 55 and 65. Wait a minute, that's Alzheimer's, dementia, the older person's disease? No, that's a disease of middle age. That's not older persons. But let's even look at this a little bit differently. If at the age of 65, 10% of people have Alzheimer's, well, that means in those people, the disease first started between the ages of 35 and 45. And that's not older age. That's not even middle age. That's still kind of earlier age. So believe it or not, there are 46 million Americans today, right now, that have Alzheimer's beginning in their brain, the amyloid and whatever other pathology, but no symptoms. And that's something we kind of don't think about. So I really believe that the field of, again, preventative neurology, Alzheimer's risk reduction, Alzheimer's prevention care, dementia prevention care, brain health, whatever word you want to use semantically, really needs to begin early. And when we started the program, we saw people 40 and above. And then I had a 32-year-old son of a patient that wanted to come in. I said, okay, come on in. I had to change the IRB. And then I had a 29-year-old a woman who actually ended up having a presenilin 1 gene. Who else is she going to see? There's no one else for her to see. So I changed the IRB again. And basically we're seeing people as young as 25 and above. And that's honestly not egregious when it comes to when the pathology begins. So I'm not going to go into too deep of a dive of, all the evidence out there. And, for those people that are listening that just don't believe that Alzheimer's prevention is possible, I get it. I was there too. A decade ago, I was confused, and 2009, 2010, 2011 is when my, definitely my metamorphosis happened. But if you haven't been aware of the studies, it's okay. It's not common too, but there are randomized controlled trials, multiple trials now that are published in real journals and in real things that show that you can change your lifestyle and do things to attack risk factors, whether it's blood pressure, nutrition. These are randomized studies, high quality evidence that show that you can delay cognitive decline. And we can have improved outcomes. So the finger study, which you may have heard of, we'll talk about that in a bit. Nutrition, exercise, cognitive engagement, and regular follow-up with a clinician. The Sprint Mind study, this is something on the bottom of this slide that I wish more people knew about. The Sprint Mind study was a randomized study, multi-years, 3.5 years. They stopped it early because the outcomes were so good. This was published in JAMA a couple of years ago. And they showed that if you use blood pressure therapies to get the blood pressure down, when one arm was 140s over 80s was the target, and the other 40s was 120s over 70s or below, just in 3.5 years of treatment, just that difference in systolic and diastolic, you can delay or reduce the risk of mild cognitive impairment by 19%. That's a lot. That's just blood pressure control. So I really believe that when you do a little bit of this, a little bit of that, and you take the totality of evidence from randomized studies as well as epidemiological data, there are things that we can do, and we've really tried to study this rigorously in our program. So what the heck is our clinic? Our clinic is called an Alzheimer's prevention clinic. Yes, I believe that's okay terminology. We've actually written papers, should this be called the Alzheimer's risk reduction clinic or the prevention clinic? And we've done, studies on this and, analyses about what the public understands. And when the public hears prevention, they understand it. When the public hears risk reduction, there's a lot of confusion. And I believe that, and various other bodies, WHO, for example, believes that the term prevention should be used when anyone is attempting to lower a person's risk. So we're zen with the term Alzheimer's Prevention Clinic. And what we do is we apply evidence-based and safe approaches. This is not a one size fits all. Different people have different genes. Different people have different medical problems. And, right now there's, a lot of medicine is a lot of cookbook medicine. And for better or for worse, it's important to have evidence-based guidelines and algorithms for sure. But Alzheimer's is a very heterogeneous disease. People with the ApoE4 variant, they're different. People without it, and they have a different gene, they're different. Men and women, different, like completely different, especially the perimenopause transition in women totally triggers. And we've published on this and others, absolutely triggers. It's one of the key risk factors for women on the decline towards Alzheimer's. And when you have the ApoE4 variant plus a woman, that's worse than a man that has the ApoE4 variant. So these are really complicated interreactions, and we try to apply the best available evidence. It's not an algorithm. Fred Plum, who I feel like was out by you guys decades ago, Fred Plum and Posner, I may be misremembering, but they came to Cornell, a while back, and Dr. Plum and I had a conversation about this specifically, and he went like this. He said, "Medicine is not an algorithm," and then he talked to me about this for 45 minutes, and it was something I remember very vividly in the year 2000 when I was still a med student. So that's the way we look at things. When it comes to risk factors, there are modifiable things and non-modifiable. You can't change your age, you can't choose your parents, but you can, change your exercise patterns. You can change what you eat. And this isn't just about, go eat healthy or go eat, I don't know, less carbs or whatever you may think. There's single nutrients, multi-nutrients, and dietary patterns, and we'll try to talk about that. The Mediterranean style diet has a ton of evidence, but then what about the B vitamins and the omega-3 fatty acids? And what is the applied science to nutrition? Precision nutrition is really where we need to go and where we're kind of, getting to now. Keeping the brain active. I joined a rock band, for better or for worse, 101 followers on Facebook. Hey, that's social activity. That's good too. Sleep is so important. Stress reduction, staying engaged in life. These are all things that are really important. And at the bottom right, vascular risk factor modification. If someone does only want to come away with one thing from this entire talk, and yes, you've heard about lifestyle and modifiable risk and that we may be able to make an impact in certain people, vascular risk factor modification is, again, aside from exercise and nutrition and things like that, cholesterol control, diabetes management, blood pressure control, stopping smoking. If you want to slam the brakes on cognitive decline and Alzheimer's disease, vascular risk factor control is something that we all have the power to do. We should all know our numbers. When a primary care doc, and I talk, I'm looking for 120s over 70s or below, and ideally, honestly, below, or that would be the max. And I talk to the primary care doctor, and we, talk about the evidence and we come to a happy medium. And I feel like we all need to work together on this. Is this a primary care problem? Is this a neurology problem, a psychiatry problem, a cardiology problem? This is a public health problem where physicians of multi-specialties really need to work together. On the bottom left here, I have a slide. This is actually a device that I wear. I wear it all the time. I have another biosensor over here. I sometimes wear a ring. I have all sorts of things that, I have a chest strap when I'm on the Peloton and things like that. So I'm a data junkie, and we slap these on people, and I know, at least in some degree of objective data, how many hours a person's sleeping, what their exercise levels are, what their average pulse and their max pulse is in each of the activities that they do. And we really refine or fine tune every recommendation. We track people, and we use these informed data sets to make better recommendations. So what exactly is the type of research that we do? It's real world clinical practice research called comparative effectiveness research. So we take the best, greatest hits of randomized studies and the strongest epidemiological studies, and what we do is we compare existing interventions for risk reduction, and we track it over time in IRB approved comparative effectiveness research studies. And we try to figure out in which patients it's going to work better. And that's really critical. Which patients, meaning with memory impairment or without memory impairment. So we divide our group into prevention and then early treatment. So mild cognitive impairment that have amyloid, that's early treatment. That's what we call it. And then we have primary prevention and secondary prevention, meaning amyloid in the brain, no symptoms, or no symptoms, no amyloid. We lump those together, primary and secondary prevention, in different groups. So this is the type of research that we do. And we try to apply emerging principles of precision medicine. Can we apply pristinely fancy, whole genome sequencing to every person? Well, no, we don't have the resources for that. Have we done whole genome sequencing on a dozen or so patients and have tried to figure things out? Absolutely. But we try to do this kind of like watered down, realistic version of, we use the medical history, lifestyle patterns. We examine people. We look at blood biomarkers like a few genetics, ApoE, we look at it on everybody. Why? It's not for diagnosis. It's for risk stratification somewhat, but it's to personalize care. And I really believe that. There was a recent paper in JAMA, multiple choice questions, CME sort of thing. And they said, oh, you have the ApoE4 gene and mild memory problems. Don't do anything. See you back in a year. JAMA is still saying things like this. And those answers are wrong, and that's the wrong way to do it. And hopefully by the end of this, and if you want to pull some of our papers, we've talked about and we've published on using ApoE in clinical practice to personalize care. We then also look at cognitive assessments. If a person has pristine cognitive function, that's one set of risk. If someone is borderline, even though their IQ is here, well, that mismatch, the difference between normal and optimal and really sensitive computer-based testing is something that we really, find important. We also look at, a whole host of blood risk factors, from cholesterol, inflammation, metabolism, nutritional markers. We look at omega-3s in the blood. We look at particle size. We look at ApoB in cholesterol. We look at insulin resistance. We look at homocysteine, vitamin B12, vitamin D. The list goes on, and we do as best as we can in this year to try to personalize care. In coming years, we're going to be able to do a much better job. So we take this paradigm we call the ABCs of Alzheimer's prevention management, try to keep it simple, but has some complexity. The A is for anthropometrics, meaning body composition, how much body fat, percent body fat, where is the body fat? As the belly size gets larger, the memory center in the brain, the hippocampus, gets smaller, especially in women. Women that have elevated visceral fat above a certain level have a 39% increased risk for dementia. Okay, that's a recent study that came out a few months ago. There's multiple studies for the last 10 or 15 years to talk about belly fat and memory loss, because metabolism and memory should be thought of in a synonymous way. It's not just about how much fat, it's about where the fat is. And metabolically inactive fat around the visceral organs is going to increase metabolic syndrome. People with diabetes have twice the risk of Alzheimer's. And guess what? If we can minimize the body fat, if we can, attack metabolism, if we can maybe use an anti-diabetes drug at some point, there's for example, this is semaglutide is now going to be studied this year in a early treatment study for Alzheimer's disease, GLP-1s, interesting data on metformin. Again, not saying to use these necessarily off-label, anything like that, but I'm just saying that the diabetes phenomenon and Alzheimer's, there's a relationship because diabetes, insulin resistance, fast forwards amyloid decline. So there has to be a relation. Muscle mass, really important too, especially, but perhaps more so in men, and we need to kind of sort this out. When it comes to blood biomarkers, like I said, a third of my time, I'm like a make-believe preventative cardiologist. I was trained 20-something years ago by Arthur Agatston, who invented one of the first preventative cardiologists. He like literally invented the Agatston calcium score to stratify people. If you have calcium in your arteries, that means your cholesterol really needs to be treated. It's the same thing with Alzheimer's disease. We can take these metrics and understand where to intervene. So we look at preventative cardiology labs. We look at a lot of, primary care type things. We look at blood pressure. We look at inflammation. We look at, again, insulin resistance. And these are things that are the B, the blood-based biomarkers. And then again, the C, cognition, which includes measures of memory. We use the NIH toolbox. We use executive function measures, processing speed and attention, language, learning ability, and also really important, odor identification. If someone is missing several items on an odor identification test, the smell test, something's probably going on. It could be Alzheimer's, it could be early Parkinson's, it could be something else, head trauma, zinc deficiency. There's a lot of stuff out there. But it's, again, it's a harbinger of something possibly to come. So what we then do is we put together as best of a risk assessment as possible, and then we do the best we can with evidence-based interventions. Because that we're doing this so personalized and like this bespoke fashion, we have to track people every 6 months in order to understand whether the multimodal things that we're doing are working. We don't know if the one thing that we're doing is working because we're never doing just one thing. On average, our patients get 21 different evidence-based interventions, and that was based on our published study in Alzheimer's dementia just over a year or so ago. And that was our 18-month study of following people in a clinical cohort from baseline to 18 months to try to figure out, does a personalized plan using these types of interventions and modulating all these labs and cognitive function, whatever else, what is the effect on cognitive function at 18 months? What is the effect on calculated Alzheimer's and cardiovascular risk? And do the labs change over time? So that was our study design. And how did we do that? Well, we did this through multimodal interventions. So I'm going to keep it simple. Here, this is easy, right? If this, then this, if that, then that. It's like a computer program. I was a computer science guy in high school. My best friend, Justin, was just texting with Justin, sat on my laptop when I was a senior in high school. And there went my Westinghouse project. There went my computer science career. So I'm the schlub that had to go to med school. So I went to med school. But this is a computer program, basically. And one day when we have all the rules for figuring out in a personalized, precision medicine-based way, if a person has this gene, then they're at this higher risk, but this therapy can help with that gene's function, and then we can do this, and this person has that risk factor. And this is a schematic of an example of how we go about all these decisions. All of these decisions are published. We have a methods paper that was also published in Alzheimer's and Dementia, the Journal of the Alzheimer's Association, back in 2018. So this is a reproducible method. It's a very long paper. It's 11,000 words with the supplement, 3,500 words with the main paper. It's called The Clinical Practice of Risk Reduction for Alzheimer's Disease, a Precision Medicine Approach. So if you really want to get deep and, need some reading materials before going to sleep in bed, every single thing we talk about in this talk today and every single thing that we do in our clinic as of that year, 2018, is in that paper. So this is all a reproducible method that the scientific approach we try to give. So the next 5 or 10 minutes, I'm going to try to give an overview of some of the things that we do. I could talk literally, for an hour just on the interventions, but again, that paper and other papers out there can help. And at the end, I'm going to give you a link to a free CME course online where we try to, at least in a couple hours, an hour mainly, kind of give you a broad brush overview of what we do. And this is all for free online on an education website we built. So nutrition and Alzheimer's disease, there's just never in a million years when I was in med school or neurology residency did I ever think I'd be, touting nutrition for brain health. Like that never made sense to me. I was not like a nutrition fitness kind of guy, didn't understand that stuff. Now the science of nutrition is something that I follow very closely. Back in 2000, there were 3 articles with diet and nutrition in the title. When I started the clinic, there were 44 articles. Now there are, I think at the last, over 3,000 articles, in 10 years. Like the amount of published information on nutrition and Alzheimer's has increased by multiple orders of magnitude. So I do think that nutrition is hard to study. I don't think that you can, eat a magic blueberry and prevent or cure Alzheimer's disease. But what you can do is think about nutrition in the dietary pattern sense and a single or multi-nutrient sense. So the Mediterranean style diet is by far the most evidence when it comes to brain health. You know, we'll talk about that in a little bit, but green leafy vegetables, you know, multiple servings of produce a day are good for you. Whole fruits are better than juice because of the sugar. Devil, again, is in the details. Fatty fish, lake trout, mackerel, herring, albacore tuna, sardines, wild salmon. Those things are like really important. I have my tuna sandwich for lunch. There we go, right there. Of course, it's on bread, and bread, yeah, I'm going to go running later, so I need some carbs. That's fine too. I'm actually, you know, I eat fish at least twice a week, and fatty fish have high omega-3 fatty acids. And in certain people with certain genes, people really need their omega-3 fatty acids high. And we'll talk about that soon too. There's been studies on the ketogenic diet, caloric restriction. Eating less is probably better for brain health over the long haul, the MIND diet. And then when we talk about nutrition, we don't just talk about the dietary patterns. We have to think about things like omega-3 fatty acids given either like as an FDA approved drug for cholesterol management, but it can also be given in either, whether a supplement form or whatever else. There's no FDA approvals for Alzheimer's prevention for omega-3s, but there is FDA approvals for omega-3s for cardiovascular disease. So, you know, the devil is in the details here, and this will be sorted out even more soon. Curcumin, turmeric, again, is this a perfect, am I telling people to go on these supplements? Well, no, not necessarily, but we talk about it. We talk about cooking with it. We talk about in certain people, based on study by Gary Small, maybe a certain type actually delayed a little bit of the amyloid deposition in a in a pre versus post amyloid scan study. These are the types of things that we need to sort out over the coming years. B complex vitamins use a ton of in my practice, but only in people that have elevated homocysteine. Why? Because that's what the VitaCog study showed. We'll talk about that in a little bit. So for each of these elements, vitamin D and caffeine and flavonols and dietary antioxidants, there's this whole scientific literature, all of this, and we can't get into it all now, but it's something that I do think you should look into at least a little bit. So the Mediterranean style diet, I think we're kind of all aware of. You know, fat is there's certain types of fat that are good for you. Olive oil, extra virgin olive oil, drink it. It's like miracle grow for the brain. These are the types of, changes that people can make that I think will really have, better brain outcomes. Red meat in low amounts, moderation, low fat yogurt and milk in moderate amounts, grass-fed yogurt may be better, maybe higher in omega-3s, need more studies on that, of course. And then alcohol. Alcohol is really tricky. Less is more, I think, when it comes to alcohol, especially if you have one or more copies of the ApoE4 variant. So these are, again, precision nutrition is where we need to go in our field. My close colleague, Dr. Robert Krikorian, did a study using a dietary ketosis, very small kind of pilot nature study, but he showed within just 6 weeks, significant memory improvements in insulin resistance, improvements in waist circumference. This is, people with mild cognitive impairment. These are people with real issues. They just made a dietary change. Now, it was a big dietary change. Ketogenic diet is not the simplest thing to do. But in 6 weeks, they were able to show something. And the studies on this just keep on coming out. We just had a follow-up study in Parkinson's disease, another pilot study. So when it comes to multimodal interventions, I really believe that, the biological principle of synergy, 1 + 1 = 3, and whatever dietary type you choose, and each study has looked at things differently. I think we really have to include exercise on a regular basis, regular follow-up by physicians, and staying cognitively engaged. And the finger study worked both in people with the ApoE4 variant and without it, and that's very important. So I think there are certain interventions that work across everybody, more one size fits all, and then there's other interventions that probably don't work as well. I could spend at least 20 minutes on fish oil and omega-3s. I like the term omega-3s much better. We have omega-3 fatty acids. We have omega-6 fatty acids. There's anti-inflammatory, pro-inflammatory. They need to be in a specific balance. This is really confusing. The evidence is murky. But what I can tell you is, based on the work of Hussein Yassin and many others, omega-3 fatty acids, in my honest opinion, based on the evidence, have to play a role to some degree in risk reduction for Alzheimer's disease. The problem is in the initial studies, in 2008, for example, the Quinn study failed. People with Alzheimer's that got omega-3 fatty acids didn't do better. Well, okay, did they have their baseline omega-3 fatty acids checked? No. So if your omega-3s are good, why are we going to supplement? That doesn't make sense. What about, let's see, what's the dose? Well, what dose do the people need? Well, we now know that people with the ApoE4 variant need a minimum of 2,000 milligrams of DHA, doxahexanoic acid, specifically to get into the, brain. They actually did spinal taps, a randomized study looking at the levels. People with the ApoE4 variant just don't absorb the DHA. So the take-home point here is it's not just about the dose. It's not just about the timing. It's about all these things. It's about the person's genetics. It's about the whole picture. So I really believe that omega-3s, obviously we always start with fish, fatty fish a couple times a week, check the levels. Levels aren't good. Cholesterol is high. These are the types of people, person has an ApoE4 or 2 variants. That's the type of person that we, really increase the omega-3 intake, as well as supplements or prescription omega-3s when indicated. So let's talk about vitamin B and the B vitamins. Again, not something I ever thought I'd be giving to patients 10, 15, 20 years ago. But the VitaCog studies really showed that B complex vitamins can help, can slow brain atrophy, can slow memory decline, improve memory function, but only in people that had elevated homocysteine. And homocysteine is an amino acid in the blood that, again, can be used as a marker for precision medicine and risk reduction for cognitive decline. Again, same thing. This was studied in Alzheimer's, no effect. And this was actually, studied in 2008. The omega-3s study, I think, was actually published in like 2011, the Quinn study, I apologize. But long story short, when you use these therapies, when someone already has dementia, and the horse is out of the barn, they've had the disease for 20 years or more once they have dementia. But if you use these therapies earlier, that's that window of opportunity for these things to work better. And during the MCI phase, if you have elevated homocysteine, B complex vitamins can be used to, I believe, really improve outcomes. The other thing here is, again, sorry to get confusing, but precision medicine, not the most simple thing. People also needed to have adequate levels of omega-3 fatty acids in the blood for the B complex vitamins to work in the best way possible. So again, there's a multi-nutrient, multimodal component. So we do use B complex vitamins quite a bit in our program. About 60-something% of our practice actually had elevated homocysteine. So about 60-something% in our study actually were given B complex vitamins. Wake up and smell the coffee. That means there's about 10 minutes left of me blabbing, so that's not too bad. And then, of course, we'll open it up for questions. But wake up and smell the coffee means caffeinated coffee probably has some sort of protective effect. Is it the caffeine? Is it the coffee? Is it the substance X that these folks in Tampa, Cowan colleagues, did some research on? I'm not exactly sure, but whether it's Parkinson's disease or Alzheimer's disease, caffeinated coffee, especially earlier in the day, I believe has a degree of protection. I do as I say, not as I do. I have my caffeinated coffee in the morning. I don't drink coffee if I can after 1 o'clock in the afternoon because it can, mess with sleep-wake cycles. Half-life of caffeine is, solid 5-6 hours and varies depending on the person. But drinking caffeinated coffee earlier in the day makes sense. And I think that the epidemiology evidence suggests that, but do we have randomized perfect trials? Well, no, that's a limitation. When it comes to flavonoids, regular intake of blueberries and strawberries, a half a cup, 2 to 3 times a week, Nurses' Health Study. Again, this was not a randomized controlled trial. This was strong epidemiological evidence, but people that had this amount of blueberries and strawberries in their diet had delays of cognitive decline for over 2 years. And some people say, oh, that's epi, that doesn't mean anything. It's epi, come on. Well, these studies have been followed up multiple times. So Robert Krikorian has done randomized studies using wild blueberries, using blueberry powder. He's now doing the strawberry randomized study. And there is a science to this, and you can actually prove, like he's done, that these materials, these components, the chemical components in blueberries, for example, move the needle when it comes to a randomized study as well. So that's, that evidence is good enough for me. When it comes to cocoa flavanols, there are cocoa flavanols that have been studied in multiple trials that not only improve, for example, memory and blood pressure control, but also insulin resistance. So every morning in my coffee, I put purified dark cocoa flavanols in, and the exact type was actually studied in multiple randomized trials, both in Italy, at Columbia, in the United States, redone done the trial. So again, the evidence is strong enough for me to use in clinical practice and then for myself. So the goal here is to try to figure out over the coming years, what is a brain healthy diet, how it differs from a heart healthy diet, and how that differs from an overall healthy diet, because in different people, these answers are going to be quite different. And just, in January of this year, the NIH really started the first ever precision nutrition push. There was the first ever precision nutrition conference I got to speak at. I was very humbled to be invited to that. And I do think that this is kind of where nutrition is going to go in the future. So let's transition. Exercise. Somebody wants to reduce their amyloid in their brain if they have it right now, today. Exercise is the only thing that we can do because we currently don't have a disease-modifying therapy. There's one that's being reviewed by the FDA and all that kind of stuff, and there's other anti-amyloid therapies out there. But in mice, and most likely in humans, more exercise equals less brain amyloid equals lower risk. Exercise is probably the most evidence-based thing a person can do to reduce a person's risk of Alzheimer's, to delay cognitive decline. And the precision component of exercise, where you do specific types of exercise based on your body composition. If you have high body fat, we want you to lose it. If you have low muscle mass, we want you to gain it. We're going to give you targeted therapies. We're going to talk about the difference between high intensity interval training and zone 2 training and strength and balance training. And we're going to put together a targeted plan for you. I've worked with Sarah McEwen, and we've, ages ago talked to Kirk Erickson. There are some giants in the field of exercise research that I've learned a ton from. And, I can't say we have the perfect recipe, but I think the perfect recipe of exercise depends on the person. Tracking pulse, tracking exercise output, tracking strain, average pulse, max pulse. These are things that I think are really important as we move forward. Music activities, even intensive musical training later in life can improve brain function. Okay. Lifelong musical experience slows brain aging and memory loss. So like Nancy said, I joined a rock band. We're the regenerates, not the degenerates, they're regenerates. Music for the right brain. And that's my crew back in Miami. And we used to have some good times. So then COVID hit and now no one's doing anything. So what are you going to do? So when it comes to stress, talk about COVID and stress. Well, it's been stressful being home alone, being home sequestered, being away from family and friends, maybe getting COVID. It's been a bad, tough year. Stress and repeated distress and worrying about that stress, neuroticism or rumination, is the number one thing that's tied to amyloid and tau deposition. And this has been shown. All stress is probably bad, leads to worse cognitive outcomes, smaller brain volumes, but neuroticism, rumination is the worst of the worst when it comes to stress. So these are things that have been teased out now. Social interaction, staying engaged, hobbies, having a sense of purpose. Countries where they have the earliest retirement also have earlier onsets of cognitive decline. Staying engaged in life and in social activity with friends and family is absolutely critical. So that's the best I can do in a 30, 35-minute overview of what we do. Again, multiple articles have been published. Again, clinical practice of risk reduction for Alzheimer's, a precision medicine approach, which is also published in Alzheimer's and Dementia. But what I would say is these are the results. This is the best that we can do in the absence of randomized studies, because what we do, again, is comparative effectiveness research. We give people with different cognitive status, different interventions. We then compare the two, how they did. And instead of using a high dose or a low dose, we use high compliance versus low compliance and compare the two groups. And then instead of having a control group, because we're a clinic, like we take insurance, we see people and we, bill for modifiable risk factors that we treat. We're a clinic, like every other clinic out there, preventative health, preventative neurology clinic. And what we do is, instead of having a control group, because that's unethical if people are coming to see a doctor, using insurance, we use natural history controls, meaning we use the Rush data set, we use the NAC, the National Alzheimer's Coordinating Center data, 38,000 people in there, and we see how those people did compared to our group. And is it perfect? No, but it's as best as we can do with real world comparative effectiveness research. And this is the results of that trial. So again, a quick overview, this is a study that we did, we published last year using these multimodal interventions. Again, each person got on average 21 different interventions. They could have gotten 15, they could have gotten 25, depending on their individual risk factors. Patients, believe it or not, were aged 25 to 86. Some of the peer reviewers said that's a weakness. Others said it was a great strength. So again, depends on how you look at it. We have very simple inclusion criteria: a family history of Alzheimer's and no or minimal cognitive complaints. In the prevention group, we included primary and secondary prevention. That's this green and yellow boxes here, meaning they either had amyloid in their brain or not, but no matter what, these people had no symptoms. In the early treatment group, these people had symptoms, plus they had amyloid in the brain. And what I mean by that is if people had MCI and they didn't have amyloid in the brain, they were excluded from that arm of the study. So this is as best as we could do, amyloid versus no amyloid. And in this study, the prevention group, we lumped them together, whether they had amyloid or not, because again, in the real world, not everyone's going to be getting amyloid. So we decided to lump them together, not just because the N would be larger, but also because if someone is practicing out there and if someone has no cognitive complaints, this is what the expected outcome could be at 18 months following this plan if you don't have, biomarkers, which is, obviously expensive and hard to get. So hopefully that makes sense, the prevention and early treatment groups. Again, what we did is we provided individual recommendations. We rated people on compliance. Two separate clinicians rated on compliance, and the person themselves, the patient themselves, also rated themselves on compliance. We compared to two matched historical controls. So again, a little complicated. Prevention, higher compliance, was compared to prevention, lower compliance, which was compared to the two natural history controls. So each group was compared to the high dose, the low dose, and then the control group, or the placebo group in some way. And again, limitations to this, but it's the best that we can do. Primary outcome measure was change in baseline to 18 months on the Alzheimer's Prevention Cognitive Composite. This is a scale that was developed by the folks at Banner to basically detect preclinical changes and early cognitive changes in people that did not have dementia. And we also looked at our risk scales, so calculated Alzheimer's and cardiovascular risk, as well as a host of serum biomarkers related to Alzheimer's risk. And here was our kind of gestalt results. And in the green dotted line on the bottom, those were the people that had mild cognitive impairment due to Alzheimer's, amyloid in the brain, that followed less than 60% of the recommendations, and that was the cutoff. If you see here, this blue dashed line here, the blue dashed line were people with MCI due to Alzheimer's that followed greater than 60% of the recommendations. And you can see people with MCI responded and there's a big error bars here. So there was a large variability in their response, but it took them longer. So that the further along a person was in their pathological process in the Alzheimer's, pathophysiology, it took them longer to respond. But by the time we got to 18 months, there was significant difference between the two groups. When it comes to the prevention group, whether they followed greater than 60% of the recommendations or less than 60% of the recommendations. And honestly, that average was, over 30% of recommendations were still followed in the lower compliance group. But no matter where you were in the earlier stage, whether you had high or low compliance, there were significant improvements from baseline to 18 months. When it comes to the risk scales, across all risk scales, all cardiovascular disease risk scales, and the two Alzheimer's disease risk scales we used, there was also significant improvements. And I can go into a lot more detail here. And in the studies, there was also significant improvements when compared to age-matched controls. But in general, and so I definitely want to leave time for questions. We have about 10 or 15 minutes left. This was the first empirical trial in a clinical setting that showed that individualized Alzheimer's risk factor management may improve cognitive function related to Alzheimer's pathology, because those cognitive tests really were basically meant to detect changes related to Alzheimer's pathology and really done in studies to track that. And secondary analyses showed reductions in calculated Alzheimer's and cardiovascular disease risk. And that was, another, supportive evidence that the types of interventions that we do are working. So from a practical clinical perspective, I really believe that multi-domain individualized care can be applied to millions and millions of patients that are at risk for Alzheimer's dementia. And I think the next logical step would be to study this type of intervention in a large multi-site international cohort. The problem with doing this is A, COVID hit, so that derailed things, and B, the funding for this type of study is not a 7-figure study, but it's at least an 8-figure study. And, getting that type of funds is challenging for this type of work. So we still have our work cut out for us. So I want to definitely leave a lot of time for questions, and I'm happy to answer any questions, of course. But if people do want to learn more, we've tried to educate the public as best as we can. We have an extraordinarily long waiting list. We just can't handle the amount of volume that people are interested to come to the clinic. And what we've tried to do is put education online that's free and available for all. This is actually an education research study. So we put a course online, people get randomized to different permutations, then we can study the effectiveness of the education. And we have online courses for healthcare providers, a CME course. We have a prevention course for the public. And then we have courses for students, high school students, college students, medical students, and neurology trainees. Seth Rogen actually was our guest professor in the randomized study. It was me versus Seth, and maybe Seth Rogen won. He's kind of a local. He's from Vancouver. Lives in California now, so he's a West Coast North America kind of guy. And it was really great to work with him and really get the word out that brain health is a topic that the younger folks really need to pay attention to. So with that, I definitely want to leave time for questions, and thank you so much.
Thank you for that fantastic talk. You really are a pioneer and, dare I say, rock star in this field.
Finally got a rock. I didn't make it in my business, my band life as a rock star. I actually got on TV once or twice for silly Alzheimer's stories. But yeah, thank you. I appreciate that. I'll take it.
The comparative research, the comparative effectiveness research design is so difficult, and I really do think that we have to get into the space of thinking differently about preventive medicine. So let me end neurology. So let me ask you a couple questions. So here in the chat. So when you find an elevated homocysteine and start, B complex vitamins, and despite good compliance when repeating the homocysteine, it's still high. Do you go on and look into methylated versions of folate or cyanocobalamin? And for example, the MTHFR gene status as an alternate B group for an alternate B group vitamin?
Yep. Great question. I would say that the exact answer here to these questions are complicated. I'll tell you what I do based on my clinical experience and based on reading every possible study I can, based on talking to David Smith, who's the PI of the VitaCog study in the UK, Oxford, amazing guy, changed the way I think about a lot of things. So what I do is, generally speaking, we recommend the usual B complex vitamins as first line for a person with elevated homocysteine. And what I mean by that is the cyanocobalamin, regular folic acid, and then B6. B6 is probably the least important of the three, and we don't recommend too high a doses. 20 milligrams to 50 milligrams is kind of like where we go. So we also do look at MTHFR. If someone does have a double mutation in 677, for example, or maybe even 1298, occasionally we may start the methylated ones first, but we generally speaking, I don't know, this is tricky because I don't know, a lot of people also just, I don't know, come in on the methylated ones because they read it on something or they heard it on a website or something like that. But yeah, we usually start with the regular ones. After 6 months, if the homocysteine is still high and the person has a double mutation or even a single mutation, we'll just put them on the methylated. And we have I have nothing to disclose in terms of brands or supplements, or I take no funding from any. I wish I did. I could pay off my student loans. But long story short, there are some brands that are really good when it comes to the methylated ones. There's even prescription ones that have been studied and are probably pretty good too, but more expensive. So yeah, we do a lot of this. Do I think it's necessary for people with a double mutation to need the methylated Bs? I don't know the answer to that. Do I think they work better? I don't know the answer to that. I think there's a possibility that they could, but I just don't know. I don't have like an objective answer, and we haven't really been able to tease that out in our data set because it's, we have a lot of mishmash in terms of people and it's hard to tease out. But yeah, I recommend methylated Bs at least, I want to say up to half of the people that are on B complex vitamins, because either they have a double mutation, or their Bs didn't, or their homocysteine didn't come down. People who, as we get older, above the age of 50, our ability to absorb B vitamins in the gut is less. So, sometimes you need higher doses. Giving a shot of cyanocobalamin. We don't do that in our clinic. Is that better? I mean, I have no idea what the answers are, but the answer is we personalize it as best as we can, and that's a really, really great, really valid question.
Thank you. And another question around dark chocolate. So could you expand more on the dark chocolate that you add to your coffee?
Sure. And again, nothing to disclose. And I wish Hershey's or Mars gave me free chocolate or whatever. I literally have been paying for this powder that I'm about to tout because of the evidence, not because of me. But I've literally been paying for it for a decade. I've been on this stuff for a decade. I'm still paying for it. It's expensive. So the type that we use and recommend in our clinic is something called Cocovia, COCOAVIA. And it's made by Mars. That's the disclosure. Again, I have nothing, no financial anything. But Mars makes it, and they made the process, they created the scientific process to understand the flavanol amounts in dark cocoa flavanols. So that's why the applied science of nutrition really advanced in the cocoa flavanol world, because of the work that they did. They did randomized study in Italy. They did another one in Colombia, in New York, looking at like hippocampal activation or something like that. And I use Cocovia in my coffee. I use my goal is at least a packet a day. The study's probably a packet and a half is probably sufficient. Some people take the capsules; those haven't been specifically studied. Probably works similarly, but I don't know. But yeah, Cocovia, I put it in my coffee every morning and mix it up, and it's bitter. I put milk in my coffee, so I do break my fast there. My overnight fast is broken with milk. That's what I do, because I can't tolerate the dark chocolate without without a little bit of something to break it up. But yeah, I really believe in cocoa flavanols. If someone has any degree of insulin resistance, or any degree of suboptimal memory, or maybe just wants a little bit of extra boost. Why do I take it myself? I think it's good for cardiovascular disease also, blood pressure control. I like the taste of it. So that's easily a reason right there too.
Great, thank you. And so another question, do individuals who modify risk factors pharmacologically, for example, antidepressants for anxiety and rumination, or sleep aids in middle-aged individuals, have decreased risk, such as taking statins for hyperlipidemia, of developing Alzheimer's disease?
This is a great question. And we literally just queried our entire electronic medical record over the last 10 years to try to answer this in like a big data way. And we also have multiple studies that I've really looked closely at. So I can quote a variety of different things. So let me start by saying that, again, nothing to disclose, they're all generic anyway, but escitalopram, old Lexapro, which is generic, escitalopram has an anti-amyloid effect in a study that came out in Neurology around August 2020. It's going to be studied with behavioral concerns in people with Alzheimer's disease. Citalopram was studied, the CITAD trial published in JAMA. There's something about escitalopram and citalopram that I've been using these for 10 to 15 years or more in people with Alzheimer's, and they seem to work better for the behavioral stuff and just in general. I think there's some sort of reason for that, and I think it's an anti-amyloid thing. So the first thing I would say is certain antidepressants may be better than others. When we looked at our data in terms of electronic medical record stuff, people that were on Lexapro and citalopram, as opposed to other antidepressants, did better, meaning had a slower rate of decline, which I think is fascinating. We haven't published this yet. And also people on statins, those people that were on statins versus not, also had a slower rate of decline. So these are all very valid questions, and you're just going to get a lot of different answers because different statins work differently. For example, atorvastatin and Crestor rosuvastatin work differently than, for example, simvastatin. The simvastatin, which was Zocor study in Alzheimer's prevention, didn't help. So I guess what I would say is statins absolutely, in my opinion, most of the time, that's my qualifier, can delay cognitive decline related to Alzheimer's or dementia, but not all statins and not in all people. And that's a precision medicine answer, and I'm still trying to figure that out. I think people with two copies of the ApoE4 variant need to be watched more closely with statins, but that's something I usually don't say when I'm being recorded because I don't really have great evidence to back that up, but it's something that I'm interested in. When it comes to rumination and sleep aids, benzodiazepines can absolutely fast forward cognitive decline. That was also in our study that we haven't published yet. But anxiety and rumination specifically, I don't have much information on, but just, SSRIs I would say are helpful. Okay, next question. The Dr. Rick Hodes, pleasure. Hopefully we can catch up at some point. So coffee, organic, and caffeine, and then comment on fasting. Great questions. Organic versus inorganic are complicated. The way that I answer this is in the United States or Canada, DDT and its byproduct, therefore DDE, has been outlawed since 1976 and 77. So even with legacy contamination, most of the DDT and DDE in the soil is probably gone by now. So do people need to have organic foods, produce, or coffee when grown in the United States or Canada? I don't know that it's that important, but people with the ApoE4 variant that have exposure to DDT have I think it was a 4-fold increased risk of Alzheimer's in a study that came out of Emory and UT Southwestern. I'm paraphrasing that hopefully. So when people have the ApoE4 variant, what I'm trying to say is I recommend that they choose organic if produce or other things are grown outside of the United States or Canada, because you don't know if they're still using DDT, which can then lead to DDE, which interacts with the ApoE4 variant to increase Alzheimer's risk. Sorry, complicated precision medicine answer. When it comes to caffeine, I am pro caffeinated coffee. I don't know if it's 2 to 3 cups, 3 to 5 cups. I have no idea. And cups meaning 375 milliliters. So, Starbucks is, multiple cups. I don't know, but my gut says both caffeine and coffee together. Caffeinated coffee is best. And there was a study by CAO and colleagues from the University of South Florida at Tampa that kind of pushed me even further down that path, but I'm not really sure. The other question is fasting. So let me give some definitions first. There's intermittent fasting, which is, in my opinion, when you're doing 24 hours or more. And then the other term is time restricted eating. I like the term time restricted eating because in most of my patients, we recommend time restricted eating, 16-hour fasts or 16 hours of food restriction several days a week, 3, 4, 5 days a week, not more than that. But basically, if you eat all of your calories within an 8-hour time period and you basically fast overnight, you can have water, tea, no carbohydrates. I do believe that can have a neuroprotective benefits, both with a longevity, anti-aging potential, but also from a mitochondrial perspective, and probably helps in some degree with Alzheimer's, but it's going to be different in different people. MCTs, for example, ketone bodies are naturally produced when someone is fasting for greater than 12 hours. And I do think that ketones are a cleaner burning fuel in the brain. I think there's probably a difference whether you have ApoE4 or not. And there's a lot of, pharmacogenomic and nutrigenomic stuff there. But yeah, we do recommend not just fasting because maybe of the, autophagy and mitochondrial and whatever else you want to say. But when you fast for 16 hours a day, you're going to also eat less total caloric intake, most likely too, and you stop, snacking at night. So fasting has really had a positive effect on brain health, from what I can tell in our clinical work. Okay, a couple more questions. Questions open-ended. Does Dr. Eisen have any experience with MND, dementia prevention, risk stratification? I've seen a few young patients with family dementia and ALS, grandpa with a foot drop. And is this limited to neuromuscular clinics, or am I seeing these patients also? So this question really actually ties into the following question, which is how much overlap is there with Parkinson's prevention and Alzheimer's prevention? To my, summary, these are neurodegenerative diseases or mitochondrial diseases. ALS, Parkinson's disease, motor neuron disease, they all have a common play with mitochondria. So if there's anything we can do to support the mitochondria, ketosis therapy, for example, fasting, autophagy, whatever words we want to use, that's something that I think may have cross-cutting benefits when it comes to preventing or reducing the risk of a neurodegenerative dementia or motor neuron disease. Parkinson's prevention and Alzheimer's have a lot of similarities, but maybe caffeinated coffee works better in Parkinson's prevention. Exercise may work better. Certain drugs may work better. Maybe urate and the milk thing. I'm not sure if we could buy that yet, but I would say there's a reasonable amount of overlap, but the metrics are different. We can do a UPDRS, we could do walking time tests, we can do digital pen. There's other measures that we could use to track Parkinson's versus Alzheimer's risk reduction effects based on the interventions that we suggest. Okay, I think time may be up. Those are perfect questions. Those are great questions. Thanks so much. Really great audience and great engagement. Thanks so much.
Thank you so much for your wonderful talk.
Great.
Your work.
Cool. Thanks, everybody.